Well, hello everyone. It's a pleasure to be here. This is a first for me. I started this new YouTube channel and decided that it might be important for people to hear the backstory of some of the opinion leaders. And today we're going to do our first one of these little interviews with Ryan Facer, who's one of the great minds out there. Can we see you, Ryan? I guess we can, can't we?
Yeah, hi Eric, how are you? Thanks for
I'm
having
doing
me.
I'm doing good. So it seems like I've known you forever, but it hasn't really been that long. Do you remember when we met?
I do. I can remember I told you the lecture you gave at a Dentsply meeting. I actually believe I know the year because it was my first time attending this Dentsply meeting. It was in 2005. And from
Uh,
then I've been following you since then, even if you knew it or not.
didn't know it. What did I talk about?
You were actually it was fantastic. You actually kind of broke the mold originally. Like you're the original disruptor in my mind because you were showing what Cavit could do, right? Like we all knew Cavit.
Ah,
It was sort of this thing that we thought nothing much more of. We just blocked out as a temporary restoration for our root canals, and you repurposed it and you used it as an obturant, and it blew my mind. And that's what I loved about it. I loved that the properties and principles of Cavit had merits that we weren't using it, and that's what I hung on to. I mean, that was really my take
no,
home.
that's great. Do you want to hear the backstory of
Oh, I
that?
love that.
Um, I went to graduate school a long time ago. I'm a little older than you. And Herb Shielder was exploding onto the endodontic scene when I was in graduate school. And of course, it's the whole warm, vertical, et cetera, et cetera. And I was being trained in just classical lateral condensation. And I heard him and I thought, God, he does have a point here that we're not probably obturating well enough. But that backfill method he used, and this was before the invention of obtura guns, was just incredibly painful because you had to pick this little piece up and run it through a flame and then pack it into the tooth. And I thought, plus the fact that it shrinks when it's in there and it doesn't seal that good. So I thought, you probably don't really have to pack this to the level he's suggesting. So I developed this technique where I did a um, regular lateral condensation with one point just to get the solidify the cone. And then what I did when I was inserting the cone, I would soak the end of the cone for 2 seconds in chloroform just to give it a little tiny bit of softness so I got adaptation at the apex. And I put the cone in, did one lateral condensation, and then I did maybe two waves of vertical condensation. So I was about halfway down the canal. And I thought, well, that's a pretty good condensation. And then I thought, well, why do I have to go through all that effort to put something in there that leaks? If I put Cavit in there, it'll expand and seal the thing off. There was literature to show that if you had a couple millimeters of Cavit, nothing leaked through it. So I air tempered the Cavit to harden it up slightly, and would roll it into a little rope and then just cram it into the top of the canal. And I did that for 10 years. And I was too embarrassed to tell anybody about it because it was kind of off of the mainstream
Yeah.
of how you do endodontics. But I have cases right now. I have three women that worked for me in the 70s. And between those three women, I have 15 root canals in them, and only one of them is showing any problems. The rest of
Wow.
them are just rock solid at this point in time. So I think it's a technique that had some legitimacy. I just wish I had been a little bit more forthright with actually getting it out there. But I was so timid about challenging the experts that I just sort of stayed over in my corner. So
Well, you know what's
um,
funny about that comment? Like, I was not an expert when you think about it, right? Like, I graduated residency in 2005. So I did dental school 99 to 2003, then '03 to '05 at Iowa. My journey was a little bit different because when I came into Iowa, I started doing endo research because of a little program that Iowa had from a scholarship at Iowa, and I got lined up with Dr. Rick Walton. And the very first thing we did is we looked at sealer coverage. So we were just
Okay.
splitting teeth, different obturation techniques. And I didn't even know how to clean teeth yet, Eric. Like this was like my first introduction to dentistry, and I wasn't even sure I wanted to be a dentist quite yet. But what was interesting is,
This was while you were in dental school,
yeah,
not graduate school.
not graduate school. I'm
Oh,
talking
fabulous.
freshman year of dental school. Had to do it over the
Oh,
summer.
killer.
Yeah, well, and I didn't know anything about root canals, right? I didn't know anything about anything in teeth. Like I said, it was still basic science in the curriculum. We hadn't really translated anything into the mouth yet. I guess the reason for that backstory is the fundamental problem I had with obturation is we're looking at coverage. Like you said, gutta percha leaks. Always has,
Right.
always will. Had some properties we like. It was a filler, but we needed this concept of a sealer. And because it's an interface, there will always be entropy. There will always be problems no matter what. And it's true because as my career went forward, it was always about innovating steps, but really it was how to be more predictable. And then we kind of never really looked at the seal. It was just how did it look on an x-ray, right? But for me, it was, I hated the junction because that's what I was asked to look at. And I hated it because it was always imperfect. All different obturation techniques. And then I did one with all different kinds of sealers. And then even the set time of a sealer, because if it leaked too soon and the sealer wasn't set, you had all these other like stories bouncing around. And that's why I hung on to what you said, because it was like, well, why didn't we just make it simpler with Cavit? You know what I mean? I get handling properties, but I didn't need, I could take a lot of those inferences, throw them in the garbage, and it served as a sealer and an obturant at the same time. And I think that's what I loved about it. And I'm like, just make it simple, guys. But again, I think that's the advantage of a beginner mind. Like I was clearly not an expert at the time.
Yeah, but you also did not have your biases hard in place so you could actually look, you didn't have to overcome your biases. The problem with Cavit is that everybody goes, well, it's a temporary filling material, right? And instead of taking a step back and looking at what the actual physical qualities of it were, um, and so that technique, I did have to admit I did not actually push it because I wasn't psychologically in a place where I felt I could do that because I was sort of intimidated by expertise. But I tell you, I got really, really good at that, and almost all of those root canals worked. I'm convinced it actually had legitimacy. So you ended up going into your sophomore year of dental school not knowing what endodontics was, but being an expert at sealers and obturation.
Yeah, truly, it was a transition from freshman to sophomore. Technically, it was in my freshman year as well. And I learned root canals before I learned to do anything else from, like I said, Dr. Walton. And I remember, it's kind of funny, he just stimulated something in my brain. Like, I remember talking to him, like, I don't even understand. I didn't, and he said something profound to me that has resonated with me. And he just said, hey, sometimes the student minds, they're the best minds because they ask the better questions. And he was a big believer in the Socratic method, right? Like he was always
Right.
like, I would never directly answer your question. I would pose another question and make you go figure it out. And honestly, I think that's kind of like the point of this conversation because I hung on to that during my whole journey, right? Even to present tense. I never wanted to lose the ability to ask better questions. And I think that leads into what we wanted to talk about today.
Well, I think it's also the reason that we're interested in each other and the way we think because it's that thing that you are continuously asking questions. You're not really satisfied with your knowledge base. That kind of drives us to be curious. And one of the things, no flattery intended here, actually a lot of flattery intended here, that I've really enjoyed about you is that you never are looking back. You got a hell of a lot of energy, more an amount that I'm jealous about. But you're always moving forward and you're moving ahead and you're going, what's the best way to do this? What's the next thing that's going to come up? And you're more than willing to leave something in the background that other people wouldn't. So one of the questions I've got now, so I didn't realize that you'd been sort of primed in your early years in dental school to have this open mind thing. Um, you went to dental school, you decided to go to graduate school, and you did your graduate training at the same school. Is
I
that
did.
correct?
Yeah, I just continued right on
So you
through.
just went straight through.
Hmm.
So when you got out of graduate school, what was your concept of the endodontic disease model and how to treat it? What did you believe
Well,
at that point?
so in dental school, classic train, step back, O2, hand file, step back type preparation, non-standardized cones with roughly an epoxy-based sealer. Like that was my definition on that side. The problem was we were looking at, and my co-residents, a resident who I'm actually partners with now above me, Randy Madsen, and then a resident, his name was Tom Goddard, that was with me in residency. Literally, we're looking at this sort of like, well, when are we done yet? Like, when is it clean? Or when is it clean enough? Or how do we get irrigation down to the end? And it was also the time where, chlorhexidine was getting introduced because we were like, hey, it's just not good enough. Like the traditional bleach, the traditional EDTA, it's just not good enough. What can we do more? And chlorhexidine was coming out, and concepts of substantivity was getting introduced to me during my residency, right? And I'll tell you what I had, the issues that I had. Like the first one was just simple, size fit model, right? Like we were needed smaller tips with safe ends, and Dentsply was kind of leading that with like the Maxi Probe. And then it was like, well, to get it to the apical 2 millimeters, how big did that have to be? And then there was also the concept that a file, if it didn't plane the walls and create a true shape, then we weren't actually cleaning the debris out regardless. And so we needed to touch the wall and hopefully stay centered, because these were, landed files were in this generation as well. So stay centered, touch the walls, and then get the ingredients, get the irrigants down to where they actually were touching the end. And so it was like astonishing how big you had to make the terminus to really even have an attempt at that. And so, in Tom Goddard's research, it was sort of like it had to be a 3504. And so, that's where the rotary caught my attention, because it's like, well, look, doing a hand file and keep hand filing with all the iatrogenic entropies I can enter inside this system and mistakes I could make, it just made sense that I was safer and faster if I just went all in on rotaries. And it quickly made me want to leave hand filing, frankly, altogether. And I just knew I could get to bigger sizes quicker, and we weren't separating instruments. And so the problem was, because I split all those teeth looking at sealer coverages, I knew it was a bad deal for the shelf life of the tooth after treatment. I just knew it, you know what I mean? And because frankly, if they were big canals, their teeth were easier to split and when I was looking at sealer coverages, right? And doing my SEMs and stuff I was doing at the time. If they were smaller, like it was really hard to break that root. You know what I mean? Like I had to really work hard and get a razor blade out and get my trough tunnels just perfect. And but fundamentally, I left residency going
So
into.
you didn't. No, you go ahead. Finish.
Oh, I was just going to say, when I left residency, I basically hung my own shingle, right? So I didn't have like a legacy bias in my practice, right? I was still to my own ingenuity and creativity. And so when I built the first practice, I wanted to brand myself about like, I had the microscope, all the technological advances, the different kinds of rotaries. That's why I got on the circuit with Dentsply. But I was focusing on irrigation and endpoints. And I just made an observation. And I was saying, hey guys, do the root canal to the best of your ability. Just do it. Just treat it. Do it, whatever protocols you want. And then actually just take bleach and flush it in there and pump it and see if there's any chemical activity, like effervescence, right? Like the bubbles
Right.
coming up, like denoting activity. Now, granted, that's limited to like a vital case and there's no communication to the bone. But I'm like, the point was you didn't know when you were really done. And I would go like that training my general dentist, and it made them want to refer to me because they're like, well, crap. It made them ask the question that it didn't have anything to do about the racing stripe to the end, had everything to do is, are we done yet? Are we clean yet? And I was trying to say, we don't know that answer, but our best guess would be this is a clinical feedback trick. And when guys adopted it, when they became in for the patient, they would struggle. They'd say, man, that's really hard to actually find an endpoint where the bleach was the indicator when to stop. Like you really removed all the organic material, for instance. And I know it's not a perfect statement, but it got the mind thinking towards this. And I think because I branded myself that way, it naturally inclined me to any better opportunities to find the proverbial endpoint of disinfection.
So early on in the game, then it sounds to me like you were somewhat suspect that the irrigation protocols you were using maybe weren't completely doing the trick, and you were uncomfortable with that. Because I personally have never been comfortable up until recently that we actually irrigate effectively. I
Agreed.
mean, I was always suspect of it. I always knew that was the little dark, dirty secret of endodontics that you may have a nice white line on the radiograph, but there's still junk inside there.
Yeah.
So was that kind of where you were at, or were you
Yeah.
pretty
Because,
convinced you were doing the right job?
well, to me, it was like, I just knew how to write. Like, I was never comfortable with entombment. And then after that, it was like my conscious, like, what is my best effort to truly give the patient the best chance? And I think that's why we relied on calcium hydroxide too, right? Like, if we can't play like laser guided missile games with bacteria, we just play horseshoes and hand grenades and try to throw
Right.
like calcium hydroxide in there, and then just that would clean up all the entry, like whatever was left behind, right? And I had a problem with that too, which is kind of funny
Yeah, it's cooking
because
the debris.
yeah, like you got it. I mean, that's a probably not a conversation you want right now on the merits of calcium hydroxide and that fallout.
Well, it's interesting. Richard Rubinstein, who was lectured a lot on endodontic surgery, is quite good at it. He and I were talking one time, probably 15 years ago, and he looked at me. He says, he says, we don't do endodontics, we do entomodontics.
Yeah.
And because we were having this conversation about irrigation and how the fact that it really was not the end game the way we were doing it. So it sounds to me like you've always been a little bit uncomfortable with this. Did you get into any other kinds of modalities? Did you keep your curiosity up
Oh
and
yeah. I mean, frankly, because when I told you if I was using bleach activity that I could see through the microscope as an endpoint, it took a long time. And so I wanted to know how to get to that sort of clear fluid, no activity of bleach looking inside a canal. And so then I would start heating things up. Like I knew that if I agitated or if I added heat to it, I could get to that endpoint in that assay quicker. And so
so
then I was
you were looking at the lack of effervescent bubbles as your
mhm.
endpoint, assuming that that was when the digestion of the debris had stopped. Is that a
Yes,
correct assumption?
that's a
Okay.
correct assumption. And so then it was just like, what do I do to ameliorate that? So heat was an option, and I would use like a fine, like off the touch and heat. That was the original one, but whatever your heated element was, I would use that. Warming, hypochlorite in a warmer, you could do it. It was just a hassle, and it was kind of a workflow problem for my assistants. So I wasn't like totally satisfied with that. And then I went on to, when I got introduced to agitation. And you remember all those little agitation devices or ultrasonics, the original, ideas of cavitation and some of those games that we were in. And that was getting popular, right? Ultrasonic tips were really prevalent, and so I was using all those type of tools that I had to try to make irrigation or disinfection or however you want to describe that better, because ultimately it was the differentiator, right? Like that's where I felt like I could stand apart. And if I couldn't prove it, like in literature, I could definitely talk about it to my GPs to the level of effort I was willing to do to help their patients. And it was, and then it was just a really strong way to build my brand right out of school.
Yeah, it's pretty hard to argue for leaving dirt in.
Yeah.
I had a knee replacement done some years ago, and of course they wheeled you into the surgery room awake, right? And I'm looking at all of these implants that are up against the wall because they're trying to figure out what size to put in there when they whack my knee. And I'm telling you, the level of sterility in the room was unbelievable, And dentists have always kind of gotten away with being a little
Dirty.
dirty is the wrong word, but the level of cleanliness inside a root canal system has always been suspect from my standpoint.
Well, you coined the term that I like the best. What do you call that crap inside a canal?
Oh, schmutz.
Yeah. So we're comfortable with a certain level of schmutz.
Right. Yeah. So the schmutz model, in my mind, embraces bacteria, and it's basically anything that's organic, carbon based is schmutz. And it's antigenic if it's carbon based, so you got to get it out of there. Plus, I like the way it rolls off of your tongue. So, did you flirt with lasers at all with this
Well,
journey you've been on?
I'll tell you a funny journey about that. I did flirt with lasers, and I came to it from a couple different perspectives. But on this perspective, you remember in like your probably like chemistry class in like high school? Do you remember that Russian guy Wingradsky? Do you remember the Wingradsky column?
Yeah, vaguely. Yeah.
And it was just like a graduated cylinder, and it was one of these science experiments you could do at home. And it was like, hey, grab some pond mud, throw it in the cylinder, get some pond water, throw it on top of the mud, put some newspaper in there, and then do like that cellophane on the top and put it out in the sun. And then you would grow kind of like a rainbow of bacteria. And it was sort of showing how chemotrophs and autotrophs differentiate in it. Well, I gave a lecture one time and I used that model about the schmutz, and basically the root canal's a filter, right? We're taking away oxygen, we leave organic material, that's the equivalent of the newspaper, the body's the equivalent of the sun, and no wonder we differentiate and we get a different kind of bacteria out the back end of the root, right? And that was my education approach to explaining why it was so important not to entomb bacteria, and because of that model. And because of that, I was looking for other energy sources to ensure that I could truly eradicate. And that's when I got introduced to like the PIPs, right? And Fatana's approach to things. And I took a class, met Rico and went down there, and I took a class, and it was the fact that I could tell it was saying the right language to me. It was the fact that I knew it was progress. It was definitely an upgrade. The problem was it was super expensive, right? And I didn't know how I felt about some sort of console in my room, the arm of the laser. But I also was running an implant side to my practice, and that also intrigued me with like the LANAP, what they were doing in periodontal pockets, and some of the surgical attributes of that. And I kind of conceded because it was, well, my gosh, I can do multiple disciplines with this thing. And we were looking at some way to normalize like the 4 different doctors in our practice at the time, like to where you couldn't really tell which doctor did it. And we were looking at that, trying to find a standard of clean amongst us all, like truly what is our brand, quote unquote, or what is our quality. And that's what led me to it. But it also truly exposed all the problems that I had with it,
Which were what?
Well, I wasn't sure that it went beyond the cervical zone, frankly.
Okay.
And those tips were really, they could break if you just tapped it on the entry point of your access. So you had to really open things up to be able to see. It worked better if you put it directly above the canal. And so you'd have to go down each canals individually. There wasn't really like a known duration that you had to run. And then the problem was, because of the action of it, you exploded the bleach out of the chamber, right? And
Yeah,
so
it's a pretty aggressive
oh yeah,
energy source.
and it popped really loud, which was kind of obnoxious. It you could ruin your patient's clothes, or your scrubs would, change color really quick. You had to invest in polyester scrubs at that point, right? No cotton allowed, because it
Right.
would just bleach out. And then you'd have to get into all these dressings. The problem was, I wasn't satisfied that there really was a protocol around it, because so much had to be where I held it, if the patient moved, if I got bleach up their nose from a pop, if my assistant had a drip or flow bleach into it at the same time to replenish it, because those pops would evacuate it super quick. And I didn't really feel like it. I just was frustrated, and I didn't feel like I was achieving the job I intended to do with it.
Did you see any clinical difference in your cases using it?
I would say yes at first. Like, I could see it in the easy talk tracks, like an isthmus between, an MB and an ML on a lower molar or something like that. But it was all very floor of the tooth based. You couldn't see beyond it. I didn't see changes to the shape, because, I mean, frankly, I didn't change my instrumentation at all. Like, I was still using, larger shapes. There wasn't like, anatomy that was popping up, with the exception of maybe some lateral canals in the cervical zone, or like something that connected to a lesion inifurcation. And it made me feel good because it had some properties to it, but I didn't know if you could control it well enough, and you could, as an operator, understand what your job or your task of that tool really was, to really be consistent clinically. And but again, my notion was, well, it's progress, it's the right direction, and like I said, it's answering those beginner mind questions a little bit better. The frustration points that I had were attempting to get resolved, but it didn't work. And when I was looking at recalls, I couldn't prove to myself that those difficult cases were actually improved. Like the stuff where I was like, man, maybe I should have done like 2-visit or 3-visit endodontics with calcium hydroxide. These larger lesion cases didn't resolve. I didn't change like post-operative complaints with like tenderness and those sorts of things. And so, after about a year and a half, I just use it for surgery. Like, I ended up stopping using it. I just kind of left it.
So it's a natural evolution away from this thing. It sounds like consistency and predictability was a bit of an issue with you.
100%. Those were the top line issues. And I couldn't see that what it did for me, it did for my partner or my other partner. And so I'm like, man, like, it doesn't really standardize us yet. And if we could standardize ourselves, then we could standardize potentially outcomes. And that was something that I wanted to try to achieve, especially because I was working in a group setting.
Right, right. So when did you become aware of this general wave system? Because obviously you're very enthusiastic about it right now. Well, how did that evolution occur with you?
Well, I mean, there was a lot of name dropping. And so people were like, hey, you should, talk to Facer about this. And, some of my colleagues who were also very progressive mindset, Steve Buchanan, for instance, and I got to talk to Bob Guyette really early on. And what was interesting, as I was doing my homework, I understood that they kind of bought PIPs, right? Like, they kind of bought that protocol,
Right.
that laser space. And At first I was like, huh, they're either going to make it better or they're going to kill it altogether. And honestly, frankly, I was just curious at that point. But I was very, very skeptical because I'm like, if they're going to tell me the same thing and I'm going to have the same setup heartache and I don't see like a value or a standardization or a qualifier out of this thing, I'm out. Like, I'm out. I'm not going to do it. But I also really like Rico, and I knew he was going to be down at
Yeah,
Tom
I
McClamy's.
love Rico. He's a great guy.
Yeah, and it was innovative of what he did and fascinating. Again, it was what I liked about Rico is the same comment I liked about you, right? And it was just breaking the rules and trying to do it for the right reason. And so I knew he was going to be at this presentation. I didn't know who else was going to be there, but I also knew this guy named Razad Kapoor was going to be there, right? And I'm like, well, I'm going to attend this thing. And I had all this respect for Tom because, you know, he was another silent hero of mine. I don't think he knew me very well at the time, but I knew him.
McClammy?
Tom McClammy, correct.
Right, yeah.
And so I'm like, well, if Tom's taking this serious, then you know what? I'm going to take this serious. So it was like a perfect alignment of people that I knew that I wanted to be around in their first introduction to it. Well, guess who else was there? Turns out you were.
Really? Was this in Scottsdale?
This was in Scottsdale.
At HDI? Really?
Yeah, HDI in 2017. And you were there. And I'm like, oh, I like this guy. And you were like, and I don't know if you remember this, but you were just questioning. And you're like, I don't understand. And you kind of cornered MK and you were asking the better questions. And so what you didn't know, I eavesdropped on that whole conversation, frankly. And I learned from you. I learned from how that engineering mind of yours broke things down. But that's what caught me. That was my intrigue, actually. So believe it or not, like you influenced that, my
Really?
adoption of the GenoWave. Because
You know, it's interesting. I'm surprised MK didn't stop talking to me because they invited me down to Laguna Hills to just check this thing out completely out of the blue. I was barely aware that it existed. And they said, well, why don't you come down next Tuesday? I said, yeah, I'm not working Tuesday. Why not? So I flew down there and got the grand tour of the office, and they did this presentation in their conference room. And MK, who I truly love today, got up there and told us how it worked. And I looked at him at the end of the conversation. I said, MK, I have no idea what you just said. It sounded all like marketing hype to me. And he looked at me with this kind of not disgusted look, but like, long suffering look. And, eventually on another trip, I went up to him. I said, you and I have got to go in your office, and we're not coming out till I understand this. And it took me literally 10 months to a year from the time I was introduced to it to where I could explain it to MK, and he gave me the blessing. He says, now you understand this thing. And it's that the method of action of this thing is so non-intuitive that it's really hard to get people to understand how it works. And unless you understand it, you don't quite see what the deal is with it. So, but anyway, he put up with me, and we're buds now. So,
well, it impressed me. I'll tell you that for sure. But you know what's funny? So I did a few of those courses, and I think I just had good luck because I saw you present your videos at another course, and MK was there, and again I eavesdropped, and I can't remember now exactly when I purchased the GenoWave, but I'll tell you who influenced me to really actually make me buy it was Steve Frost. And the reason why, what was funny, now that I'm remembering the story, what was funny about that was he said what I needed to hear. He bought like a month or two or whatever it was before me. And what attracted to me was the ability to get all the younger associates and his group to sort of have a protocol of standard that they could live by. And he kind of adopted to that by his own pathway. And then for me, I was like, I'm all over that. And then I felt bad that he was ahead of me, you know? Steve and I have a great relationship, you know, just always, you know, it's like he and I always kept each other in residency together because we always were blowing each other. You know, you always have your buddy that you geek out
Yeah.
with. I did that with him and still to this day do that with him. But it was the fact that I could make a clinical assumption of where I really felt like I was affecting patients' lives for the good. And then I was all in with him, you know, at that point. So that's really what pushed me over the edge. And it truly speaks back to the shortcoming of the laser because you couldn't get everybody to do it the same. And you couldn't sort of not guarantee, since that's too strong of a word, but ensure at least predictability like you could with the GenoWave amongst providers.
Right. Yeah, that's an interesting comment because one of the things that I've come away from being exposed to this device is that there's a consistency to the protocols and there's a predictability to the protocols. That if you set the thing up right and you do your due diligence in trying to allow it to work, it does the job for you, and you've got some confidence that it does that on a routine basis. And I think that's a really powerful thing. It frustrates the people who want to MacGyver everything because we
Yeah.
have all of us dentists have a little tendency to want to, put our own thumbprint on how we do things. But and you can't do that here. You gotta behave yourself and do what the protocols are. But I like that feature that you've got a very consistent, research driven, data driven way of doing the thing. And if you do it that way, it'll work. Um, so how did I guess one of the other questions I've got here is that when people first start looking at this device, they look at it as a really expensive needle irrigation.
Yeah.
They look at it as an irrigation device. And it's sort of been presented that way because people can kind of get their head around it. But it really isn't. It's
Right.
more than that. And how did you develop from the time you first started using it to today of understanding what this can do for you and how it can change your whole concepts of endodontics? I mean, how does it change what you got out of graduate school with versus today?
Well, good or bad, it changed everything. And it was something that I couldn't change back. Like once I got in, I couldn't do it. I couldn't change back to where I was.
You
And I
couldn't
appreciate
unsee
that.
it.
Yeah, I appreciate that comment when you said I don't go backwards because that's a kind of a philosophy in my internal life right now, right? Like I never want to go backwards, just only forward in things. But, you know, God, there's just so much to talk about on that because in some ways you could accuse me of doing some MacGyvering. But in a lot of ways, I just knew that there was a frontier that was undefined that needed further questioning, further innovation in as far as not understanding fluid dynamics, but understanding how to better employ fluid dynamics. And because I kind of came into the game thinking that with the PIPS journey, I knew that it wasn't an irrigation because I knew from like the old school stuff, like the stuff in the 1920s. And, you know, remember the whole medicament era, you know, where people were
Yeah.
trying to like prove an endpoint and success, that it really had nothing to do with the obturant as it seemed like the shift and the tide of endodontics went. It just made sense that this job of the GenoWave would do more than instrumentation, that it could do the job of the file, that it had more potential. And I was connected to this idea that, man, if I got a better starting point, then I will always have a better outcome. So in other words, if I have something really, really dirty and I put a file in it, I know I generate smear. I know I push the physical form of the file, pushes whatever I'm into elsewhere. Yes, I have relief with flute design and flute dynamics, but I saw all the manufacturers battle flute geometry because I mean, frankly, I did this experiment with a file in a closed loop system, and I won't name the file, but when I was doing a benchtop with this new file design, it was like I was making a sausage wiener out the apex of the tooth because it was pushing
Right.
everything out. And I'm like, well, no wonder people complain. That's going somewhere. And truly, when I got connected to fluid dynamics, I realized that it would never do that, especially if you could maintain this negative apical pressure concept, right? And so I started experimenting on the condemned teeth, like the stuff that was like slated on my implant side of the practice. And I could rehabilitate that. Like I could get true resolution. And all I did is ran the GenoWave and then obturated. And I'm like, well, my goodness, there were some unique things about those situations, but
So
it made me,
you were experimenting in clinical cases that you had mentally condemned
yes.
with this, and you're getting positive results back out of it in what you would consider to be very, very poor prognosis cases.
Yeah. So because of that, and because I realized my case opportunities would increase, some of the manufacturers' contraindications, for instance, or some of these sort of higher risk scenarios, man, I could problem solve them better if I modified the protocol. And it kind of, I felt so bad, Eric. I don't have 10 years with Cavett like you did when you were kind of doing a similar thing, but I did it. But I was having such good success that I thought, man, I gotta leak this out a bit. I gotta tell my partners. I gotta tell other confidants, other parts of the country to get them to try to change their protocol. And then finally, I just felt so bad. I ratted myself out. I called up MK and I said, I got some good news and some bad news. Good news is, man, I know how to get the GenoWave to be used in more cases, and my outcomes speak for themselves. The bad news, I changed the protocol. And it was just, I just did the protocol in a different order set, is what I did. But I felt like it maximized the opportunity of fluid dynamics to give me a better end result and hence a better outcome. And they started calling it the Facer protocol, which sometimes makes me a little bit,
Well,
self-conscious about it.
you're famous now.
Well, I don't know about that. I don't mean to be, but I love that it opened up the possibilities for a different direction. And I love the opportunity it gives the potential in saving teeth.
Yeah, one of the big challenges in something like this is that um, is getting rid of the old knowledge that we have and replacing it with new knowledge, but doing that in kind of an appropriate way. And if you think about what it took to get us to where we are, let's say you're 10 years into practice, right? And you've got this sort of mental model of that you operate off of, what do you do for irrigation? What do you do for cleaning, shaping, all of that stuff. I mean, that journey is a long journey. There's a hell of a lot of energy put into that, a lot of time, a lot of money, and that has substantial value to you. And it has substantial value because it identifies part of what you are and part of how you make your living. And if somebody comes up and goes, maybe you need to rethink part of this, it's an effort to do that rethink. And one of the things you've been able to do, and I think I really appreciate in you, is you're kind of you haven't you've given yourself permission. It sounds like down through the years to let go when something new comes up and you've evaluated it kind of appropriately. And that's actually not a very common attribute, I don't think, in people. I think it's relatively unique. And I think that's one of the reasons you've been able to come up and go, I'm going to think about this a little bit differently. Because one of the problems that clinicians have had with this device, even though they like the fact that it's this great irrigation device and disinfects and et cetera, is that they're not letting go of some of their older protocols and biases, and they're kind of doing the job twice kind of a thing. It's like people get all anal retentive about their um, apical diameters, right? And you don't
Yeah.
have to worry about that anymore. you
Touche.
know, and it's like what can you let go of and still do the job properly? And it's been interesting to watch the evolution of the way people think about this. Once they realize that this device is actually a different thing, it's a new technology that works in a different way from the old technology. Now that we have that, how does that change everything else we used to do?
Well,
And
to your point that you're making, which is so valid, Eric, it's so important to like reiterate, just echo back to you what I heard you just say, because I mean, another way of saying it, simply put, we were making our job harder than it needed to be when we employ fluid dynamics.
right,
And
exactly.
trying to say it's this, got to do this fancy platform build and just use it as an irrigation device, and then all the things that happens if you would hang on to your prep, your length determinations and your apical prep sizes, and then the frustrations, that love hate relationship, like we just were making the job too hard. And so I like how you said that, because it connected to like the epiphanies that I had. Like it was like, man, if I could keep fluid dynamics in its purest form, it became a panacea, like a true panacea, like the environment, like back from that connection to the old Greek goddess, and sort of the Latin connotations of that word panacea. Like it really gives us that panacea. And then it was like my job just had to be how to employ it more predictably and better, etc. And it was easier once I let everything go.
Did you suddenly come to a realization, for instance, that your patients were having a different experience?
Oh yeah. So let me come at this from my office manager's perspective. What's cool about the practice that I grew into, my office manager's whole career in dentistry, and she's older than I am, has been in endodontics, right? So she had even more sort of legacy bias than I did, like as far as just time in the practice, clinical practice of things. So she's 30 some odd years into it, and I'm like, I don't know, whatever, I guess 21, whatever, 16 years into it. But she said to me something profound. She's like, you know what, Ryan? Here's what's interesting. Not the marketing attributes, not the even having the ability to speak towards the clinical. She's like, here's what our patients are saying. It's actually the first time that people are asking for the technology by name. She's like,
Wow.
people didn't call us and say, hey, you got digital x-rays? Hey, are you using cone beam? Like they didn't call us on the phone and ask for it. Now, the reason why that's impressive is it's not I'm not talking from the perspective of like good marketing from Son Endo, which is, hopefully will be a true statement. But it's from the perspective that my patients were talking about it. And people were saying, dude, that's so cool. I've had, root canals in the past, and this one was so different. And, I really fostered a word of mouth style practice build approach to my practice. And I knew how to empower that out of the patient. But what it did is it caused my own, like a unique kind of referral pattern. And then patients promoted it to the GPs, and it just kind of like worked, and
So they were coming back to the GPs with positive stories,
yeah.
and then the GPs were asking you about it.
Well, it just didn't
And
make sense to them.
did you anticipate this, or
Oh
is this
no,
just something that came out of the whole thing
no,
that you weren't
totally,
anticipating?
totally unanticipated, truly kind of an accident. Like I said, I did tiptoe into it. Like I gave myself a full 6 months before I even really would even talk about it, because I wanted to prove on the 6 month notion of recalls that I could prove something, that I could honestly look everybody in the eyes and say, this gives me a better practice. And
Right.
that was the gap I had with PIPs, right? Not only from me, but also from my partners. And, with Dr. Matson and I, we aligned ourselves in that way, and we just looked at everything differently. And we tracked things differently, like the way our patients would come back, the way we'd get our touch points, but indirectly, it promoted us, and over the time, we were at two endodontist practice at that point, and now we're 7.
Wow. So this was just an evolutionary process that the device itself created.
Yeah, it truly, when I truly embraced it, it really did change everything. And it wasn't a bad change. It was a natural pivot to the practice's culture.
So I've thought a lot about where we are in endodontics. I've been obviously doing this for a long time. And I mean, when I came into practice, there was no such thing as nickel titanium, and
Yeah.
there was no Obtura guns. I mean, I was early in the game, so I've seen most of the evolution of endodontics,
Yeah.
and it seems to me that we've gone through a couple of different phases in endodontics. Clearly, the first phase is the whole disease model of apical periodontitis is caused from bacteria, and we get rid of that by cleaning the thing out. And then the improvements in metallurgy gave us nickel titanium. Ben Johnson gets some kudos for that, obviously. And then there was this, and that was kind of the end wave in a way of the first part of endodontics. And then we got into an appreciation of the fact that we probably were damaging teeth because of these shapes were so big. And microscopes fortunately came along, and so we started downsizing and paying much more attention to tooth anatomy, paying much more attention to tooth strength from a restorative standpoint. And I look at that as kind of a phase 2. And it seems to me that we're entering into a phase 3 now, where we suddenly have a technology that allows us to confidently and predictably debride these smaller spaces that we've been driving toward. And it's kind of a culmination of where we've been headed in the last 10 or 15 years. So, which takes us, I think, to today. But where do you think we're going to end up in another few years? What's the future hold for us?
Huh. That's a really deep question if you really internalize it.
Well, you're a
Because
deep thinker. That's why you're here.
well, look,
Give
you
me,
brought
give
up,
me your best shot.
yeah, I'll get, well, you might be, I don't know, hope you like my answer. So here's a funny perspective. Like you make reference to this statement in your own way, and I hang on to the words you choose because words are so powerful. And they mean things, and your intent of the word can mean something to you, but it may mean something to me, and it may make us go off in lateral directions. So let me wrap this around to your question now.
All right.
So the idea of the word canal at its core really constricted the ingenuity, the creativity, and the innovation. And what I mean by that is I can remember a story from Rick Walton telling me about a debate in Chicago where Frank Wine was up there, back in those days, open platform, open mic, and advocating for the MB2. And everybody was like, well, they're there sometimes, but not all the time. And then it was like this big debate, like how often are they there, right? And he gave us a categorization of canals, classifications of canals. And then you can propagate that to like Vertucci. And he just made it like more complicated. Because like, well, actually, there's a lot more canals. And you, like with your anatomy textbook, like when I think about that, if I could kill the word canal, if I go back in time into literature, I hang on to Guido Fischer, and he's like, oh, well, it's a root system, And so here's the propagation of the future. Truly fluidodynamics creates systems and system openings. And it is a term we use, we just deviated from. But if I never want to create a canal, and I want to stay true to those you know, True Hess is the more popular one than Guido. But if you look at that, why aren't we treating like that? And the problem was we never had the right tool, right? We had piano wires and stainless steel and then nickel titanium. Now with fluid dynamics, the paradigm in some ways goes back to earlier history of endodontics, but the future of it is, God, if we could tie a fluid cleanse process to a fluid fill process, well, that achieves like the holy grail of endodontics. Like, and if we could identify a true endpoint, well, then it's like, oh my gosh, like the potential left in the tooth will be its greatest because of physical crystal structure strength of the root and the inner, the whole mechanics of the tooth. We have no concept of entombment. And if we could create a true closed system, which the sound build platform creates, then it goes back to your earlier story we talked about of how sterile some of those surgical environments really were. Well, if we could do that without ever breaking the PI off of the tooth, the procedural instrument off of a tooth, we really keep a closed, controlled environment from soup to nuts for the first time. Now, those are lofty claims and lofty goals, but the innovation in that direction is really powerful when you think about it like that.
Yeah, well said. Well said. I think that's where we're kind of heading in this thing, and we clearly aren't there yet. But the cleaning out part, I think, is darn near there. I'm incredibly impressed the more I get into this at how effective this technology is. And it's taken me a really long time to get my head around that, because it does two things. It activates the chemistry we use with all of the sonic energy that developed from the cavitation clouds that are in there. But secondarily, it also refreshes the solutions. And I've seen some SEM work where some really, really, really tiny spaces were cleaned out with this technology. And I think we are approaching something where we can look at it and go, this is really pretty clean inside. And now all we've got to do is leave that instrument in place and see if we can figure out how to obturate it. And I'm enthusiastic enough about science that I think there's probably a potential for doing that. So,
well, I think it is. And that energy you talked about, that excitement, I mean, man, look how, like, I got that excitement from Tom McClammy, right? Like, truly as a clinician. And he talked about that thrill of the fill. And we all quote him because it's such a powerful statement, because it's the epiphany that I cleaned something I couldn't clean before. And the fill was just that I could show it.
Right.
And he was sort of talking a lot about like just that the job of the file was just to create a path for the fluid, right? And it's an exciting time. I mean, like, think about it. How long have we been stuck in the old ways? Like, truly stuck in it. Like, it's well over 100 years.
Yep.
Now the possibilities are just completely different.
So let's leave it at that and revisit this whole subject in the future as things progress. Do you have any comments as we close this? Any thoughts that we can live with and hang our hat on?
Well, honestly, I think the better question is to turn that right back on you. Make Dr. Walton proud with the Socratic method. I love what you're doing. I love your mind, the ingenuity and that creativity and the connection you have to us and, companies like Sonendo, because I learned from your brain breaking down the physics and the science, and then your ability to visualize that. Like, those videos you've made are just something else to watch. They really teach everybody. And I just got to give you a shout out for that. But then just kind of urge you to keep doing this platform, get all the great minds together, because I think this format that you're attracted to really has a potential to innovate the future direction of our specialty. And so For what it's worth, my parting thoughts are right on you. I can't wait to see what you're going to ask next and what you're going to come up with and who you're going to talk to.
Well, thank you very much. I appreciate the compliment. I love doing those videos. One of the things I've done down through the years is not believe everybody, and I go do my own bench work.
Yeah.
And it's surprising how much BS is out there. But this bench work taught me how this thing actually does do the job. And my hope in the near future is to get a bunch of more people like you that can get on there, and we can kind of pick each other's brains a little bit and see how we're developing the thoughts in endodontics. So with that, I will bid you adieu. I
Yeah.
thank you very, very much for putting up with me and being my first victim in this.
You're so welcome.
And we'll talk soon. Thank
My
you.
pleasure. See ya.
Bye bye.
Bye bye.